I now invite our esteemed guest faculty from UK, Dr. V. Sampat, for his keynote address on ochriplasmin, to inject or not to inject.
Thank you, Vishal. Good afternoon to one and all. At the outset, I would just like to thank Partha and the scientific committee for humbling me with this invitation. So without much ado, I'll just start off. The question here is ochriplasmin, to inject or not to inject? I think Dr. Lalit Verma has given the answer, but I'll still proceed with my presentation. So when there is a critical level of liquefaction that occurs in the vitreous, it weakens the vitreoretinal interface, and when that weakening is sufficient, then a PVD occurs. If not, we are left with an incomplete PVD. And this adhesion, due to the incomplete PVD, may have several sequelae. One of them is vitreomacular traction. You could have a macular hole, or if it is in the periphery, you could have a retinal tear. The culprit really being incomplete PVD. If you look at this picture here, you can see that the vitreous is in close contact with the internal limiting membrane. The internal limiting membrane itself is composed mainly of collagen 4, but there are other extracellular proteins involved in the adhesion, namely laminin, fibronectin, and collagen 8. The diagnosis of VMA, VMT, and macular holes have actually tremendously improved because of advanced imaging systems such as the OCT. And at one point, we had this ochriplasmin, which came as a pharmacological option, an alternative to previous standard waitful watching strategy. The real-world outcomes at that time, with careful patient selection, it demonstrated that the results were consistent with, or in some cases even better than, the pivotal studies. We all know the ochriplasmin works by liquefying the vitreous and causing the vitreoretinal separation. When 125 micrograms is injected into the human vitreous, the estimated duration of biologic activities ranges from 16 to 42 days. Gandorfer's original paper said there was no damage to the retinal morphology, although this is debatable now. But his statement might actually be true if we wait for sufficient time, because whatever damage is caused to the retina is said to be reversible. Some of the studies that came in at that time, focusing on the full thickness macular holes with vitreomacular traction, we had varied sort of success rate for resolution of the VMA. If you go to the one at the bottom from the Cole Eye Institute, Singh et al. Had 2 cases where both of them were successfully resolved. He, of course, had a third case which was taken away from the study because of the size of the macular hole being more than 400 microns. Now, Stallmans, who was part of the MIVI Trust trial, his paper showed very clearly that whatever you get at the 28-day stage will remain like that. And that's how the final outcome at 28-day stage was arrived at. Now, his paper also showed that there was more than 2-line improvement in a quarter of the patients and more than 3-line improvement seen in 1/10 at 6 months. Now, 1 year exactly after the FDA approved the ochriplasmin, we had the National Institute of Clinical Excellence, which approved ochriplasmin for the vitreomacular traction. Many surgeons jumped up with joy, and I found myself to be one amongst them. I'm going to discuss 2 cases of macular holes with you, which I treated with ochriplasmin. The first case is a 58-year-old lady with a macular hole sized 360 microns. At preoperative stage, you can see the OCT with the VMT tugging on that, leading to a macular hole. The visual acuity was 1/60. Ochriplasmin was injected, and within 4 weeks, we had good resolution of the traction, but the lips are still sort of wide apart. Visual acuity is still maintained at 1/60, but there's a huge amount of subretinal fluid. At 5 weeks, the lips are in contact with each other. Visual acuity is improved to 2/60. There is still subretinal fluid. At 3 months, that reduces a little bit, but vision has improved to be 3/60. So there was a 300% improvement in vision. Patient was happy. We were happy looking at the pictures and the vision. Now, she came back at 5 months. Vision was still maintained at 3 months. And then she comes back after 26 months, where the vision has dramatically improved to 6/12. And we find that the contour is almost restored except for some disruption at the fovea. She comes back 3 years later, and the vision has further improved to 6/9, and there's a near normal foveal architecture on the OCT. My second case, that of an 80-year-old lady with some amount of dry AMD. The macular hole measured 114 microns. Preoperative stage, the vision was 6/36. You can see the tractional element there. 2 months after the ocriplasmin, vision improved to 6/18. We are left with some amount of subretinal fluid. And at 12 months, there's near normal foveal architecture, and the vision has dramatically improved to 6/12. Of course, there is a little bit of drusen from the age-related macular degeneration. She comes back in 21 months after the ocriplasmin. Vision has further improved to 6/9, and this gets maintained at 32 months. So just to summarize, 5 months after ocriplasmin, vision has improved only to 3/60. Macular hole is closed, but there's minimal subretinal fluid. This is the first lady. 26 months from the injection, it dramatically improves to 6/12, and there's complete closure and elimination of the subretinal fluid. 36 months, further improvement, near normal foveal architecture. Second lady, 2 months after ocriplasmin, macular hole closes, there is minimal subretinal fluid, vision improves from 6/36 to 6/18. 12 months after the injection, dramatic improvement to 6/12 with elimination of the subretinal fluid. And 21 months and 32 months, we have visual acuity further improved to 6/9 with normal foveal architecture. I've used Haller's paper here to do a little bit of discussion. There are treatment differences in favor of ocriplasmin, generally observed across each subgroup of subpopulations studied. If the macular hole is less than 250 microns, they are more likely to achieve non-surgical full-thickness macular hole closure. A categoric 2-line or 3-line improvement in vision is seen if the patient is younger than 65 years or with a lower baseline visual acuity of less than 65 years. So in conclusion, our cases call into question the plausibility of the 28-day fixed day to assess the final outcome after the ocriplasmin injection, especially in the macular holes. So it's too early to decide about the results, and we need to wait for a bit longer. So these cases have elucidated the long-term positive outcome of resolution of full-thickness macular hole after treatment, where vision has improved even 3 years after the treatment. Some kind of remodeling is taking place within the retina, and therefore we really need some higher resolution imagery, which may be available in the future, which can throw further light to unravel the magic seen in similar cases. Points to ponder. It came out of the magic, like magic from the dust, but went away, declined in use, fell into disrepute, mainly because of the ill effects, darkening effects, so-called darkening effects seen in patients. But again, remember, they are temporary, and these are related to more of the ellipsoid zone, the ISOS segment changes, which become apparent in week 1 and can range anywhere up to 6 months, depending on various papers that I've reported. Further information is definitely necessary, and the Orbit, Ozone, OASIS trials which have taken place have not given us the full answer. So really, case selection is of paramount importance so as to know what responds well and what may not. Prognostic indicators, predictive factors are definitely necessary. Just for example, the pre-existing or pre-operative ellipsoid zone changes can be a prognostic factor, say for macular hole surgery. And similarly, this is what we need. Thank you for your attention.
Thank you, Dr. Sampat. Doctor, a quick question. Although I don't have much experience, I had injected in just 2 patients in University of Toronto. Patients, they come with unexplained loss of vision sometimes, and they usually say that you should not give it at the weekend. And suddenly they see a wavy kind of thing or a shaky vision. So all these kind are explained. So I just wanted to know your experience of it.
I mean, I've been very lucky. I've given about 15 ocriplasmin injections, and I've had good success in 13 of them.
Okay.
And 2 of them, I didn't see much of a difference, mainly because of probably associated comorbidities like AMD, because I look after the AMD patients as well. So I might have been lucky, I must agree. But again, I think the darkening effect can be quite denerving. And I don't push them to have the ochriplasmin. I offer it as, because if you see, the cost of vitrectomy is about 12,000 pounds. The cost of Jetria is 3,000. So I tell them that there are these effects, but I also tell them that we need to be patient. If you do end up getting some kind of an ill effect, we need to be patient because those effects have been known to be reversed. So we just need to be patient.
And what's your minimum threshold for visual acuity in a case with VMT?
Good question, because I mean our visual acuities have ranged actually. I usually wait until the vision is dropped to 636, to be honest with you. I don't give it any better than 636. That is my own decision.
Is it still available in the UK?
It is available. It's been banned in the US, but it's still available in the UK. But I haven't used it for a few years now. Of course, the COVID came and disrupted the thing. But henceforth, I'll go very careful on that one, I must agree.
Okay. Great. Thank you so much.
Thank you.
We have a question from the audience.
Thanks, Sampat. What is your threshold at which you would offer vitrectomy? Say at 28 weeks, the macular hole is not closed. So how long do you wait before you decide you're going and intervening surgically?
Okay, so I mean, if you look at the OSS and the the trial, OSS especially, across these trials they found differences. They in fact found the rates of retinal detachment and things like that to be much higher in vitrectomized patients than the ochriplasmin. So, I mean, that may not answer your question completely. I probably don't know. Given the disrepute that it has fallen into, I think one needs to be careful. But the explanation to the patient preoperatively, I think, is of paramount importance.
Thank you.
Thank you.